Well, good morning. I would like to thank you all for allowing me to speak today. I feel very privileged to work where I work and to interact with a lot of you on a daily basis. So I'm going to talk about chest emergencies, so basically neck to belly, what can possibly go wrong. So we're going to discuss the strategy to evaluate a patient with an emergency related to the chest. We will review pathology of various conditions and discuss some of the EMS treatment for those conditions. I just put this picture in to show that there is really a lot of structures in the chest that can lead to a patient having an emergency related to the chest that you may be called for. I'm not going to go over each thing, but I think we all know there are a lot of structures there. I like to try to simplify things and think in terms of our primary survey. ABCs are kind of the forefront of what you do and also what I do in the emergency room. So I'm kind of breaking it up into that. We're going to start with airway and breathing, which will cover the lungs and trachea. Then on to circulation, which will cover the heart, as well as the aorta, IVC, and pulmonary vessels. And then briefly we'll talk about esophagus and diaphragm. So a lot of this is very review, stuff that you do every day in assessing the airway and breathing. This is your primary assessment. You're kind of doing a lot of these things in concert, asking the patient if they're okay, you're assessing their mental status, determining if their airway is patent, look, listen, and feel for breathing. It's not something you do one step at a time. You're kind of doing this all in conjunction as you're seeing the patient. And really need to think about is, do I need to intubate this patient? Is their airway stable? Are they in such respiratory distress that they're not oxygenating or ventilating well? And are they having a good enough mental status in order to protect their airway? So is the airway patent? Is it obstructed? You're going to listen to the breath sounds and then note the quality of the breath sounds. Are they wheezing? Are there rhonchi? Are they diminished on one side versus the other? And then looking at the trachea also to help you figure out maybe what's going on with the patient. You know, is it in the midline as it's supposed to be, or do you notice that it's deviated? And then is there any trauma to the chest wall? Is there crepitance? Is there an open wound? Things that we need to evaluate. So we're going to start with some pathology here. So pneumothorax, which is a hole in the lung, allows air to collect between the parietal chest wall and the visceral, which is the lung surface. Normally those two surfaces are touching. There's a little bit of a fluid lubrication there that allows you to breathe. When there's air collecting between those two surfaces, it impairs normal breathing. The hole can result from something traumatic like a gunshot wound or a rib fracture. It can also occur from a rupture of a bleb in somebody with emphysema, or it can also occur spontaneously. So symptoms will often be chest pain and dyspnea. The treatment is going to be supplemental oxygen, pain control, and ultimately they're likely going to have a chest tube placed. There's just a schematic diaphragm of a collapsed lung with the pneumothorax. Here's an x-ray of actually almost the same thing. So you can see, I'm sorry I can't do the laser on the other side screens, but you can see that the lung is collapsed here and there's an absence of the lung markings on the periphery of the lung. So this patient was actually a spontaneous rupture, young male that came into the emergency department. And after we put the chest tube in, which you can see extending here, his lung is fully re-expanded. So what do you think about this x-ray? Definitely not right. Anyone want to suggest what might be going on this one? You guys awake? So first thing noticeable is really doesn't seem to be any lung on this side. Does that seem pretty clear? And then there's a lot of stuff on the patient's right side of the chest. It does look like they're intubated. You can see the ET tube coming down into the trachea. But what's really wrong with this picture is that everything is deviated towards the right side. So what normally should be in the midline, all of these structures have deviated to the right. So this is not something we usually get a chest x-ray to identify. We should identify this clinically. There's another picture of the same thing. Sorry for the quality of the x-ray. There actually are not a lot of x-rays of this available. So this is a tension pneumothorax. You can get a progressive buildup of air in the pleural space. The air can escape into the pleural space, but it can't get out. So you get a one-way valve effect, which causes progressive buildup that eventually pushes the mediastinal structures to the opposite hemothorax. And this is something that obstructs venous return and can lead to arrest. So early symptoms, hypotension, decreased breath sounds on one side. If you notice JVD or jugular venous distension in the neck. A late finding is tracheal deviation, and the treatment for this is going to be emergent needle decompression, and ultimately they'll end up having a chest tube placed. So there's just another schematic diaphragm. Basically, your air is getting into this pleural space, it can't get out. Ultimately, the pressure just becomes so great that it shifts everything to the opposite side of the thorax. Just going to review some basic lung pathology, talk briefly about all of those topics. So pneumonia is actually the most common cause of death from infectious disease. It can be bacterial, viral, fungal, tuberculosis, and also aspiration. Symptoms can include tachypnea, tachycardia, fever, chest pain, and frequently a cough. Treatment is going to start with oxygen, IV access for fluids, antibiotics, and if the patient is in septic shock or has low blood pressure, we may ultimately use vasopressor agents as well. So a pleural effusion or hemothorax is an abnormal collection or amount of fluid or blood in the pleural space. This can be caused from infection, heart failure, cirrhosis, cancer, drug-induced, also connective tissue disorders. It can occur after surgery, and also if it's blood, it's usually a traumatic cause. Treatment is going to be supportive with oxygen, intubation if necessary, and ultimately a chest tube will have to be placed to drain the fluid. And that may also be placed in order to figure out what is causing the effusion. Then you can send the fluid off for analysis. So COPD, something I'm sure you're all very familiar with and see often. It's actually broken up into bronchitis and emphysema. The definition of chronic bronchitis is excessive mucus production causing a cough, minimum of 3 months out of the year for 2 consecutive years. Emphysema is distension of the airspace distal to the terminal bronchioles and actual destruction of the alveolar septa, which leads to airway collapse during expiration. So symptoms is cough, often with sputum production, dyspnea. Treatment is going to be bronchodilators, corticosteroids, supplemental oxygen. And I'm sure you've all heard about this hypoxic drive concept that typically the cells in the body respond to elevated CO2 levels to increase your respiratory drive. Since these patients usually retain CO2 and have constantly elevated CO2 levels, their cells instead respond to low CO2 levels for their respiratory drive. So you don't want to over-oxygenate them for fear of suppressing that respiratory drive. Ultimately, if their patient's hypoxic and you're needing to give them oxygen, if you're suppressing their respiratory drive, they may need to be intubated eventually, but I would say your first goal is to get the patient oxygenated, not for fear. Don't be afraid to suppress that respiratory drive, because then you can intubate the patient if that's what's necessary. But just something, a concept to consider. So asthma is actually a reversible airway obstruction. It's hyperreactive tracheobronchial tree. The symptoms are dyspnea, wheezing, often a cough. Again, the treatment very similar to with COPD. It's oxygen, beta agonist nebulizers, corticosteroids, and also magnesium and epinephrine for the more severe cases. And as always, intubation if the patient's in extremis and needs that support. So pulmonary edema is excessive amount of fluid that collects in the space between the alveoli and capillaries. And that's where the normal gas exchange occurs. So when there's fluid there that the blood and the gas aren't in direct contact, it impairs the gas exchange and can lead to hypoxia. There are cardiogenic and non-cardiogenic causes. which we'll talk about in a minute. Symptoms will be dyspnea, orthopnea. You may see the frothy pink sputum, tachycardia, and you may also see lower extremity swelling, especially in cardiogenic causes. Treatment is going to be supportive with oxygen, positive pressure ventilation if the patient's able to be on CPAP or BiPAP. If not, you may have to intubate the patient. So the cardiogenic cause is that the heart is not pumping effectively, which causes backflow into the pulmonary arteries, increasing the pressure there, which forces the fluid to leak into the space between the alveoli and capillaries. Non-cardiogenic causes are destruction of the capillary bed, which can be from pneumonia, aspiration near drowning, narcotic overdose, trauma, smoke inhalation, and also high altitude. Again, when that fluid leaks out into the space, it impairs oxygenation. So now we're going to go on to circulation. We're going to initially talk about the heart. So we'll cover MI, pericarditis, heart failure, and tamponade. So myocardial infarction is occlusion of the blood through a coronary artery, which usually leads to death of that tissue. I think these are symptoms we're all very familiar with: chest pain, a sense of impending doom, diaphoresis, shortness of breath, nausea, vomiting, anxiety. So STEMI is obviously one that we're very concerned about because we can treat that rapidly, and the time to balloon is kind of a key thing that we're looking for. That's when you have complete occlusion of the coronary artery, causing muscle cell death to a large area of the heart. And that's opposed to a non-STEMI, where it's a partial occlusion of the artery, causing a portion of the heart supplied by the affected artery to die. So I'm just going to go over a couple EKGs. This was a 6-year-old gentleman that came in with chest pain, short of breath, really sweaty. He was actually in Columbus from out of town for a wedding. Came down into Grant around 11 o'clock at night, had been dancing on the dance floor, and all of a sudden had these symptoms. And he looked like this guy's having the big one. So this first EKG doesn't look too bad. I mean, I don't see anything, not real, you question maybe in lead 3 here. It looks like it, but if you actually draw the line there, it's not elevated. So we repeated an EKG in 5 minutes, and now you can see changes. He's definitely elevated here, starting to elevate in AVF and starting to have some changes also in AVL. So we called a STEMI alert, got him to the CATH lab, and he had a 99% RCA occlusion. So I think this is a good case to point out, obtain repeat EKGs. The story's good. If you're worried about the patient, it's a dynamic process. This literally was a 5-minute later EKG. We were worried about the patient. I said, I can't believe his EKG is normal. Repeated it, and sure enough, it was positive, and he had a stent put in and left the hospital the next day. So again, this is an inferior MI affecting usually 2-3 in AVF. This was a gentleman who was a truck driver driving through Columbus, developed some chest pain, called the squad, and this is their first EKG. That does show ST elevation. There's some pretty big ST depression. So he actually, in the squad, had a VFib arrest, was cardioverted, briefly went into PEA, and then had a return of spontaneous circulation, pulled into Grant talking to us. He went to the CATH lab and had a 90% LAD lesion, which you can see on the CATH report here, with a thrombus. So he also got a stent and did very well. He was lucky he called the squad when he did. I think if he had arrested in his truck, he may have wrecked or might not be here. So that was a pretty cool case. And then this is another patient that you can see the ST elevation in 2-3 and AVF. Pretty dramatic. He's got the reciprocal changes with ST depression here. So he went right to the CATH lab. Here is his pre-stent CATH image. So you can see on this image here, there's a complete occlusion. Nothing's going through. So he had a 100% proximal circumflex artery occlusion after his stent. Oops, well, I'm just going to show you both again anyway, but after his stent, great blood flow. So it's pretty dramatic from that to that. He also did very well. So just a quick review of the coronary artery anatomy. We have the right coronary artery, the left main, which gives way to the left anterior descending, and then you have the circumflex artery. And so we talk about inferior aneuroseptal, lateral wall, and posterior wall. And we see with inferior ST elevation in 2, 3, and AVF. With aneuroseptal in the precordial leads V1 through V3. Lateral wall, you'll see it V4, 5, and 6. And then a posterior wall, you'll see ST depression and leads V1 and V2. So pericarditis is an inflammation of the pericardial tissue, which can occur from trauma, uremia in a renal failure patient, infection can occur after a viral infection, after an MI, due to aortic dissection or a tumor. And this is usually a pleuritic or positional chest pain. Patient will also be tachycardic, have a fever, and you may appreciate a rub when you listen to their heart. The EKG in the first few hours to days of this will show often diffuse ST elevation with PR depression. The treatment is anti-inflammatories, pain medication, and steroids. And then congestive heart failure is failure of the cardiac muscle to effectively pump blood to meet the metabolic demands of the body. The symptoms will be shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, so the patient saying, I have to sleep in a recliner or sleep with several pillows, cough. You may see leg swelling, tachycardia, palpitations, usually pulmonary edema with rales, and then also jugular venous distension. So the treatment is dependent on the patient's blood pressure. If they're normo or hypertensive, you're going to treat them with diuretics, vasodilate them with nitrates, morphine, and positive pressure ventilation if necessary. If they're hypotensive, we're going to use ionotropic agents like dobutamine, digoxin. If they are needing pressors, dopamine, norepinephrine, or phenylephrine. And then a pericardial effusion is when you have an abnormal collection of fluid between the visceral and parietal pericardial surfaces. A small amount of fluid that accumulates quickly can be very symptomatic for a patient, whereas somebody that may have a cancer or some other process that it builds very slowly can end up having a huge effusion, and their body has been able to compensate for that. I think a good example of a patient where a small amount of blood in the pericardium in like a traumatic situation can be rapidly symptomatic and fatal. So the causes would be cancer, pericarditis, again, connective tissue disorders, uremia, drugs, and then trauma. We consider blood to be that fluid that collects. This can become problematic when you have a pericardial tamponade. This can either be large or uncontrolled pericardial effusion. And again, it doesn't have to be a large effusion if it's a very acute accumulation of that effusion that causes pressure on the heart muscle and basically prevents the heart from contracting and relaxing normally. The symptoms are referred to as Beck's triad to help remember. It's hypotension, distended neck veins or JVD, and then muffled heart tones. The treatment is supportive basically until you're able to do a pericardiocentesis and withdraw that fluid. Okay, so we're going to talk briefly about the great vessels in the chest, the pulmonary vessels, aorta, and then the inferior and superior vena cava. So pulmonary embolism can be, we usually think of it as blood, but you can also have fat, gas, or a foreign body that clots in the pulmonary arteries. Typically, they come from deep venous thrombosis in the lower extremities or pelvis. Risk factors are travel, immobilization, a recent surgery, exogenous estrogen like birth control pills, also pregnancy, cigarette smoking, and a hypercoagulable state. So patients may know that they have like factor V Leiden that predisposes them to clot. The most common finding is actually tachycardia. They may also be hypoxic. Often it's a pleuritic chest pain. You may appreciate a thrombophlebitis in the lower extremity. They may also have hemoptysis. The treatment is supplemental oxygen, anticoagulants, and in cases where the patient is in extremis or very sick, having a strain on the heart, they may undergo thrombolytic therapy or even thrombolectomy, thrombolectomy. So here's just a diagram of, typically the clot occurs in the veins and then travels up the IVC into the pulmonary arteries. So it can be pretty catastrophic when you have a big clot sitting in here, taking out an entire lung, or it can take out both lungs. This was a patient that I saw. It was a young gentleman that came in acutely short of breath. I think he was 29 years old, had no medical problems whatsoever, had pleuritic chest pain, and his saturations were in the 80s on room air. Even on oxygen, really wasn't that much improved. So it was initially thought that this was an infiltrate here. Kind of has a wedge shape to it, which ultimately it turned out that it's an infarct to the lung. So he ended up, once we sent him for a CAT scan, determined that he had heavy PE burden in both lungs. He ultimately arrested. We got him to the operating room, and they actually opened his chest and took the clot out. But unfortunately, he was brain dead due to, we had CPR immediately done in the emergency department, but it just wasn't that, the pump was so plugged up, the arteries were so plugged up, even with good CPR, we weren't able to circulate oxygen to his brain. So luckily he was an organ donor, but this was a pretty humbling case. I mean, somebody that had no reason to have it and died from that in our hospital is pretty dramatic. So we're going to talk about aortic aneurysm next. This, I think, is often confused with dissection, so we're going to talk about both of them. Aortic aneurysm is weakening of the wall of the aorta, causing the wall to balloon out. The larger the aneurysm, the weaker the wall, the greater the risk of it rupturing. Risk factors would be age over 60, male, hypertension, cigarette smoking, either coronary or peripheral arterial disease, and then a family history of having this occurred. So symptoms can include abdominal pain, flank or back pain. You may appreciate a pulsatile abdominal mass, nausea, vomiting. It may be syncope. They may not have pain at all. Treatment's going to be supportive, IV oxygen, and transporting them basically to definitive management, which would be a vascular surgeon. So here's some images. Here's a abdominal CT. We're at the level of the kidneys here. And this is an enlarged aorta. You can actually see the calcification in the wall. This is actually the lumen that the blood, this is contrast from it's a contrasted scan. I apologize, I don't have the measurements, but this was a large enough aneurysm that he had this repaired. Here's just a schematic diaphragm. So this can occur in the thorax or all the way down into the abdomen. It can be an abdominal aortic aneurysm. So you can just see that there is ballooning of that wall. As opposed to a dissection, which is a tear in the inner wall of the aorta, which causes blood to dissect between the walls of the aorta. As you can imagine, it's rapidly fatal if it involves all three walls. You just bleed out after a few pumps of the heart. I'm surprised the mortality, they say, is only 80%. I would think it would be closer to 100. So if it doesn't completely dissect out, this is something that we can diagnose and treat. Symptoms are usually a sudden onset of severe tearing chest pain that radiates to the back. They may have pleuritic pain if it extends into the pericardial sac. The treatment is IV oxygen and strict blood pressure control because oftentimes these patients are hypertensive, and that's just putting more stress on the aortic wall, which increases its dissection and increases the potential that it will completely dissect through. So these are patients that are often, they're being transported from another facility to definitive management, are going to be on blood pressure drips, esmolol, things like that to keep the blood pressure as low as possible. So the typical concerning chest x-ray finding is a widened mediastinum. So you can see here, it looks a lot wider than it's supposed to. And I've got some CT scan images. So this is the aorta here, and you can see this dissection flap. I have the same patient on a different view. So this was starting as an ascending aneurysm, and you can see it coming down, went all the way down the length of the aorta. And ultrasound is a great way to diagnose this, something that we do a lot in the emergency department. A little bit hard to see, but this is the aorta, and this is the flap coming right down in here. So SVC syndrome, something rare. I actually saw my first case of it in the emergency department just last month. Direct obstruction of the SVC, either by clot or more commonly by an external compression, by a tumor, like a right upper lobe tumor of the lung, a thymoma, or mediastinal lymphadenopathy. Symptoms would be dyspnea, facial edema, they may have a headache, and you may see that their neck and upper body veins are very distended and protuberant. The treatment is typically supportive. They'll do chemo and radiation to decrease the size of the mass if it's an external compression, also steroids to decrease that swelling. And the patient I had seen, she just had a hypercoagulable state and had a pacemaker wire that initially caused it, and she just had complications. She actually went on anticoagulant therapy to prevent it, since it was within the vessel as opposed to an external compression. So now the esophagus. There can be some catastrophic issues related to the esophagus causing chest pain. Other times, like in the case of esophageal spasm, it can just mimic more serious things like something going on with the heart. And then foreign body is also something that we see. So perforation of the esophagus is most commonly a result of medical instrumentation, so somebody that just had an endoscopy done. It can also occur with a lot of vomiting, that the pressure causes the esophagus to tear. It has a fancy name of Boerhaave syndrome when it occurs that way, and they estimate that to be about 10% of cases. This has a high morbidity and mortality if not treated. Excuse me. Symptoms are severe retching and vomiting, followed by severe retrosternal chest pain, and you may also have upper abdominal pain. So that's just something you can ask the patient if their pain started after, their chest pain started after vomiting. That'd kind of give you a clue that that might be a cause from this. The treatment's going to be fluid resuscitation, antibiotics, because the contents of the esophagus leaking into the mediastinum can cause mediastinitis, which is usually what leads to the morbidity and mortality in these patients. And then definitive management is going to be surgical. So esophageal spasm is uncoordinated contractions of the esophageal muscle. Can actually mimic the pain of chest pain. The treatment is similar to how we would sometimes treat an MI with nitroglycerin, calcium channel blockers, and then acid suppression therapy, as it's usually due to some untreated GERD. And this is not something that you guys pre-hospital or that I'm able to make a diagnosis of usually in the emergency department. It's just something to consider as an alternative cause for their pain. So esophageal foreign body, this was a case I saw at Children's. This little boy was having his diaper changed, and his mom had a charm bracelet on, and that's actually the mystery machine from Scooby-Doo, was that charm that fell off right into his mouth and was lodged in his esophagus. I just think it's a great picture. You can actually kind of see the bus. So just to consider if it's esophageal or if it's in the airway, based on the patient's symptoms. There was a good history. The mom saw it fall in the throat. He was actually, respiratory status was completely stable. We did the x-ray, and sure enough, there it was. And just important to consider like coins and batteries. I know there's been a lot in the news more about batteries recently, that those can be very problematic because they cause necrosis of the esophagus. So those are things that are going to be treated quickly. So we'll talk about the diaphragm briefly. I think a lot of patients have a hiatal hernia, and they attribute that to their chest pain. You can also have, usually in a traumatic situation, a traumatic rupture of the diaphragm, where you'll actually see the intra-abdominal content in the chest. So a hiatal hernia is a herniation of the upper portion of the stomach into the thorax through a weakness of the diaphragm. This can also mimic symptoms of other serious problems like chest pain, shortness of breath, abdominal pain. So here's just a schematic diagram. Typically the the esophagus goes through the diaphragm, stomach, below the diaphragm, With a sorry, can you guys still hear me? With a hiatal hernia, this actually gets pushed up into the chest. I actually had one case recently of somebody that had a hiatal hernia that then ended up perforating. I don't know that I'll ever see that again in my career, but that is a possibility. Had severe chest pain and left upper quadrant abdominal pain. I was actually working him up for an MI when we did a chest x-ray, and we could see that his stomach was in his chest, and then figured that out. So that can cause catastrophic chest pain. Diaphragmatic rupture is rupture of the muscles of the diaphragm. It's usually due to trauma that basically results in herniation of the abdominal contents into the chest. As you can imagine, the symptoms would be respiratory distress, coughing. If it goes unnoticed, you can actually end up seeing symptoms of a bowel obstruction. And the treatment with that is also supportive until surgery. And I think that was it. I didn't want to cut into lunchtime, so I'm glad I finished with 25 seconds to spare. Do you guys have any questions? You just hungry? I think